Well, I think it's time to get started here. So I'm Jeff Bieber. I'm a community rheumatologist and actually graduated from this residency program. So I was in your seat at one point, for those of you who don't know that. And we're going to talk about gout and pseudogout today. So I have no financial disclosures. That was simple. Some of the goals are to know how to diagnose gout, how to manage urate lowering therapies, know how to manage an acute gout attack, know potential complications of gouty arthritis, and recognize other types of crystal-induced arthritis. So we're going to start out with a case. A 38-year-old man is evaluated for an abnormal serum urate level of 7.9 milligrams per deciliter that was obtained at a health screening performed at his place of employment. All other measures from the comprehensive metabolic profile were normal. He drinks 2 alcoholic beverages each week, usually on the weekend, and eats meat several times weekly. He has no other pertinent medical history. Family history is notable for his father, who has gout. The patient takes no medications. On his physical examination, his temperature is 37, blood pressure is 120/80, pulse of 66, respiratory rate 12, his BMI is 24, and the remainder of his physical examination is unremarkable. So what is the next best step? And I think that we've got audience participation going on here. And polling is open. The next best step: A, Probenecid; B, Allopurinol; C, no treatment; D, Colchicine; E, Febuxostat; or F, Pegloticase. Am I correct that there are places that you can vote? Okay. All right. Okay. All right. Where's the clicker? Okay. Well, I'll give you just a few more seconds to ponder that question, the next best step. Got several treatment options. You've got no treatment. And by the end of this, we'll know more about each of these treatments in detail. All right. So let's move on here. And the majority of people absolutely got this correct. No treatment. So in this case, we've got someone who has a high serum uric acid, but he is asymptomatic. So the correct answer is no treatment, because we don't want to treat asymptomatic hyperuricemia. A diagnosis of gout is not based on a serum uric acid level. So take-home point: do not treat asymptomatic hyperuricemia. All the other listed options are treatments to lower serum uric acid, but they're only indicated if we've confirmed a diagnosis of gout. So your first step is always confirm gout. So a little bit about the epidemiology of gout. It's a disease of adults and does not affect premenopausal women. There are a few exceptions to that, but in your clinic, for the most case, you can rest assured that if you've got a premenopausal woman that has an acutely swollen joint, that gout needs to be really, really low on your differential diagnosis. There are rare genetic conditions and acquired clinical situations where that might be an exception. Someone who's on cyclosporin for an organ transplant, for example, something like that. So between puberty and middle age, gout occurs exclusively in men. Then at menopause, there's an abrupt rise in the frequency among women. So looking at this in a little more detail, the prevalence of hyperuricemia in men is 21.5% if we use a cutoff of 7, and statisticians in this study came up with an equivalent cutoff in women that would have been around 5.7, and it gives you a prevalence of hyperuricemia of 19.1%. That drops to 4.7% if you use that same cutoff that we do in men of 7. So the prevalence of gout is only 5.9% in men and only 2% in women. So just to drive home this point that we don't treat asymptomatic hyperuricemia, or you'll be treating a bunch of people who don't have gout and will never get gout. The lifetime risk of gout, if you've got hyperuricemia, turns out to be 15 to 50%, kind of depending on the level of hyperuricemia and other comorbid issues. And again, the level of uric acid, the prevalence of hyperuricemia is relatively stable in men after puberty, but it rises 25% in women as they age. So estrogen promotes uric acid excretion in the kidney. So you see this sharp jump at menopause. Gout is more common if you also have these comorbid conditions: kidney disease, hypertension, diabetes, cardiovascular disease, and obesity, the so-called metabolic syndrome. It's more common in Native Americans and less common in Asians. And the prevalence is increasing, as we reported in this paper in a number of different studies. So the take-home point, do not treat asymptomatic hyperuricemia. You've got to confirm the diagnosis of gout. So another case, a 65-year-old man presents to the ED with acute swelling and pain in his right knee. No history of trauma. It started suddenly this morning, and it's getting worse. He can no longer bear weight on his right knee because of the pain. And 6 months ago, he had acute pain in his great toe that resolved after 3 days without treatment. He has a history of hypertension and diabetes. Medications are metformin, amlodipine with hydrochlorothiazide, and low-dose aspirin. His temperature is 100.1, his blood pressure is 142/74, pulse of 95, respiratory rate 15, and a BMI of 29. His right knee is warm and swollen, it's tender to palpation, and there is decreased range of motion. All of his other joints are normal. So which of the following is the next best step in management? And your options are to get an MRI of the knee. You could obtain a serum uric acid level, you could aspirate his knee, or you could start colchicine. So I'll give you a minute to think through those options. Imaging, a blood test, a procedure, or just start colchicine. I don't have any music, and you wouldn't want me to sing, so just let you think for a few seconds about that. All right, let's see what we've got here. So absolutely, 100% good. You're going to aspirate the knee. So always with acute monoarthritis, you're always going to aspirate the joint. And the reason is you want to exclude infection. If there's bacteria in a joint, it can destroy the joint within a matter of hours. So you've got to exclude that. An MRI won't diagnose gout, and you would never treat empirically until you've aspirated the joint and excluded infection. So how do you diagnose gout? So at the top of the list there is aspirate a joint and find monosodium urate crystals in the joint fluid. You could also do some types of imaging, such as an X-ray or an ultrasound, and we'll get to that at the end. And you can find really diagnostic changes of gout, but only in long-standing advanced disease, and I'll show you some pictures of that. You could find definite tophi on physical examination, and then at the bottom here, some authorities, some texts will still include podagra, or swelling and pain at the first MTP joint. Most rheumatologists won't include that. I can tell you I personally aspirate the first MTP joint because there are other diseases that can look exactly like gout, such as basic calcium phosphate disease or calcium pyrophosphate deposition disease that can affect the first MTP. And if you take someone like that and put them on allopurinol, they're not going to get any better. Also, if you're looking at a premenopausal woman who has podagra, you sort of need to think twice about jumping to a diagnosis of gout. So we're going to go through each of these in more detail, starting with the top. So this is a large tophus that's being aspirated and pulling out this thick white material. At first glance, if you've never done this before, you might think that all that is pus. It looks a little bit like pus, but it's really not pus. It is just full of monosodium urate crystals. This is a large tophus. This stuff is thick. It's hard to pull through the needle, so if you use a small gauge needle, like a 25 gauge needle, it will inevitably just clog up the needle and you won't be able to get any of it out. But if you took the stuff and smeared it on a microscope slide, it would look like this. You'd get these crystals that are obviously linear or needle-shaped. And then if you're lucky enough to have a compensated polarized light microscope, which there's one at all the hospitals, you just have to go down to the pathology department and ask to borrow it. And you don't have to stain the slide, you just put a tiny drop on the slide with a cover slip and you look at it and it's going to look like this. And you can see some things here that the crystals that are oriented in this direction are all blue and crystals oriented in this direction are yellow. And then there are a few that we've caught in this plane that are sort of straight up and down, and almost some of them are a little bit blue and other parts of it a little bit yellow if it's straight up and down. And on exams, they still want you to know this. So monosodium urate crystals are strongly negatively birefringent. In other words, they're yellow in parallel with the orientation of the compensator. Now you would have to be told the orientation of the compensator, and on many microscopes you can look down on the bottom of the microscope and there's an arrow there to tell you what orientation it is. On all the newer microscopes, to make it even more confusing, you can flip that around and make the arrow point the other direction. So you have to know your microscope to a certain extent. But this is the same crystal over time. So it's simply floating around in fluid on the slide, and in one moment in time it's at this angle, another moment in time it's at this angle where it really doesn't light up at all, and then when it moves over to this angle it turns yellow. So we know that this is the orientation of the compensator, yellow in parallel. Yellow in parallel is always gout. If it's blue when parallel, then you're going to think about calcium pyrophosphate deposition disease. So, another way to diagnose gout is to find typical X-ray changes. Again, this is only going to happen in long-standing disease. This is someone who's had gout for a long time, perhaps misdiagnosed or underdiagnosed or undertreated. And what we see here is really a destructive process at this DIP joint. And there's something peculiar about it in that if you look carefully at this erosion, the periosteum of the bone is lifted up a little bit right here. And it's doing the same thing at other places where the periosteum is lifted up. Normally it wouldn't be sticking up like this. If this was rheumatoid arthritis or psoriatic arthritis, that edge of bone would be flat and it would be at the same plane as the rest of this bone. And so that is characteristic of a gouty erosion and is diagnostic. But you're only going to see it in someone who's got long-standing disease. The third way is to find definite tophi on physical examination. Now sometimes this is really obvious, like this kind of case. These are large tophi, and if you sort of pull the skin hard over this, it turns a bit white because it's just a mass of monosodium urate crystals that's grossly visible. You don't have to have a microscope. It's huge. And if there's any doubt, you could take a little needle and put it in here and suck a little bit of that out and put it on a microscope slide. But these are definite tophi. In other cases, it's not as obvious, and you really have to be good at looking for these. So these are some tiny tophi on someone's ear. And again, if you were to take a little tiny needle and just prick that and put a little of that fluid on a microscope slide, it would be full of monosodium urate crystals. And these can occur virtually anywhere. I've had referrals from dermatologists who found these in odd places like the thigh, and nobody could know what it was, and so the dermatologist biopsied it and it comes back gout. And so you need to be on the lookout for these. They can occur on the hands. We think about them in the coolest areas of the body, like perhaps the elbow, perhaps down in your feet, perhaps on the hands, but in someone with long-standing disease, they might be anywhere. So these are some other large tophi, and obviously this person has practically no use of the hands. We've got big problems here. And then finally, this statement that some authorities will still include a typical case of acute monoarthritis affecting the first MTP joint. And in the right clinical setting, in most primary care offices, that still holds water. And as I reviewed different resources, this is still recommended in MCSAP. It's still talked about and up to date as a method for diagnosing gout. But I can tell you that in my office, where I really need to know, I will always aspirate the first MTP joint. So here's an example of podagra, swelling, pain, tenderness in the first MTP joint. In this picture, it also looks like there's some of the ankle. So increasingly in rheumatology offices, we're using musculoskeletal ultrasound. And if you've never seen this, it's just a great tool. We're at the bedside, we've got an ultrasound probe, and we can give the patient instant feedback about what might be going on with them. And this is also now on the ABIM exam. They're giving you musculoskeletal ultrasound pictures. And I'm not going to try to make you an expert here, but this is an ultrasound of this person's MCP joint right here. And when ultrasound bounces off of bone, it creates this physics phenomenon called anisotropia. Well, this is different from that, but the ultrasound is literally bouncing off this layer of bone, which is the MCP joint head. It's bouncing off and it's reflecting again because the synovial fluid is full of crystals. So you get this sort of two contours, or the so-called double contour sign. Stick that in your brain. The double contour sign on ultrasound is virtually diagnostic of gout. Okay, it's another imaging procedure that we're more commonly using now. Done in a different plane, you can sometimes see these tophaceous deposits. And then on power Doppler, there's increased signal in the joint fluid. So we know that this is an increase in blood flow within the synovium, and this tells us that there's inflammation. This is not a specific finding at all, like this is, but these are other things that we might see on ultrasound of a joint. And so if we look at that finding of the ultrasound double contour sign, in some studies, the odds ratio for gout is really good. It's 7.2 with a p-value that's highly statistically significant. And it really approaches this value of finding a tophus on physical examination. Okay? So increasingly we're relying on things like ultrasound. Hyperuricemia can happen for other medical conditions. There's a genetic contribution in 60%. People who have kidney disease are more likely to have hyperuricemia and hence gout. And certain medications. So don't forget your diuretics, especially hydrochlorothiazide, which is now combined with lots of other blood pressure medicines. Some patients come in and have a list of their medications, and they might include amlodipine, but they didn't write the HCTZ part or the HCT part on their medicine list. And unless you know that or ask them about that, you'll miss it. There are certainly others like cyclosporin, alcohol, pyrazinamide, ethambutol, and rituximab. Any condition that causes a high cell turnover. Okay, examples include psoriasis, hemolytic anemia, hypo or hyperthyroidism, hyperparathyroidism or hypoparathyroidism, myeloproliferative and lymphoproliferative diseases, lead intoxication, and again, this point that estrogen promotes uric acid excretion. There are some genetic enzyme deficiencies and some cases where you might have overactivity of certain enzymes that lead to gout. And I want to point out fructose over here. Don't overlook that. because if you look on the bag of the potato chips that you just read, high fructose corn syrup is hidden in everything. And when I'm counseling people with gout about diet, that's one of the things that I really emphasize. High fructose corn syrup promotes gout. So, treatment of gout. We divide treatment of gout into treating the acute flare of arthritis and then the chronic treatment to decrease uric acid burden in the body and to prevent flares from happening. So, you've really got three choices for the acute gout attack: steroids, colchicine, and non-steroidal anti-inflammatory drugs. Steroids can be given a number of different ways: orally, intravenously, intramuscular, or probably the safest way is to just inject it right in the joint. I can use the lowest possible dose that way, and I can put it right where it counts. Colchicine, given at a dose of 0.6 milligrams twice per day. Never give more than 1.2 milligrams of colchicine in 24 hours for any reason, okay? So the old method of giving colchicine every hour until someone's miserable and going to the bathroom with diarrhea, don't ever do that to somebody. It's no better than giving it twice a day, and that's been shown now in randomized studies. So don't give more than 2, and never give IV colchicine. It's an incredibly toxic drug, especially when given IV. Non-steroidal anti-inflammatory drugs also work. Note that there is no difference in efficacy between the agents. So using something like ibuprofen or naproxen is just as good as using something like Lodine or indomethacin, okay? You don't have to put somebody on indomethacin if they've got gout and naproxen if it's something else. They're equally effective. A little bit more about colchicine. There are lots of drug-drug interactions with colchicine. So we avoid strong CYP3A4 inhibitors or P-glycoprotein inhibitors in patients with renal or hepatic impairment. Examples include clarithromycin and the protease inhibitors. Gout is always tricky in someone infected with HIV because of the medicines that are used and often because of other comorbidities, things that cause high cell turnover. And then don't forget about things like cyclosporin and the cardiovascular drug ranolazine. So indications for pharmacologic urate lowering therapy. So if you've got a TOFUS or TOFI by clinical exam or imaging, you're definitely going to put somebody on urate lowering therapy. If you're having frequent attacks of gout, that means more than 2 per year. If you've got chronic kidney disease, defined as stage 2 or worse, which includes a lot of people, or past urolithiasis, so kidney stones. If you've got someone who's in one of those categories, then you're going to put them on something to lower their uric acid. We don't make this decision lightly, because if you're deciding to put someone on urate lowering therapy, you're committing someone to lifelong therapy. This is something that they're never going to stop. So we don't make the decision lightly, and if someone has had just one gout attack, it's their first episode, you've confirmed it, you're still not going to put somebody on urate lowering therapy. You're going to wait, because this is lifelong therapy. Sometimes with modification of diet and activities, some people will not have another gout attack, and they don't need that lifelong therapy. So you're not going to start urate lowering therapy during an acute gout attack, because all urate lowering therapies can cause an acute gout attack. It's important that you get this concept so that you can explain it to your patients. And it comes down to really basic chemistry. If you change the concentration of urate in the body, you can cause precipitation, whether you make the concentration go up or if you make the concentration go down. And in this case, we're going to make the concentration go down. You can precipitate gout crystals and hence cause gouty arthritis. You need to be careful about that. And you need to carefully explain to a patient that, yes, we're putting you on a medicine for gout that can cause gout. And you have to have that discussion up front, or your patient will come back and not be very happy. When you start urate lowering therapy, Again, you're committing someone to lifelong treatment, and we're not going to start urate-lowering therapy on the first gout attack. Important concepts. And then you're going to continue urate-lowering therapy at the dose that achieves the target uric acid level, which is less than 6, and you're going to continue that for life. Unless there's a contraindication, the first urate-lowering therapy is a xanthine oxidase inhibitor, which is either allopurinol or febuxostat. There are 2 of them on the market. For practical purposes, allopurinol is cheaper, and so it's the one we generally choose first. If you start urate-lowering therapy, then the goal is to get the uric acid less than 6 at a minimum. To put someone on allopurinol and have their uric acid continually be 7 is not achieving anything. You're causing potential toxicity from the medication, and you're not going to prevent complications from gout down the road. If you're going to use urate-lowering therapy, you've got to keep adjusting the dose until the uric acid is under 6. In some cases, studies have shown that lower is better, keeping it under 5, particularly someone with a high urate burden or someone with a lot of other comorbidities like heart disease. You've got to keep adjusting the dose, adding therapy or changing therapy until you get there. All urate-lowering therapy increases the risk of a gout attack, so we're always going to use some kind of prophylactic medication to prevent that. And that can be with a non-steroidal anti-inflammatory drug, or it can be with colchicine. You're going to start the dose of allopurinol at 100 milligrams per day or less in people with moderate or severe chronic kidney disease. And we're going to talk about that more in a moment, but allopurinol is also made in a 300 milligram dose. You would never start someone at 300 milligrams. Why? Well, we already talked about it, because you're going to lower uric acid. And if you lower uric acid rapidly, you're going to cause precipitation in a joint. You're going to cause a gout attack. If you lower it gently, you're less apt to cause precipitation. You're less apt to cause a gout attack. You gradually titrate the allopurinol up to your target, even if the dose exceeds 300 milligrams per day, even in chronic kidney disease. Okay? So where did that come from? Well, in 1984, Handy et al. Published this study about the allopurinol hypersensitivity syndrome. And what they concluded was that for people who had kidney impairment, chronic kidney disease, there was an increased risk for getting hypersensitivity to allopurinol. And what they proposed is that if your creatinine clearance was 20, 60, or 100, that the dose of allopurinol should be 100, 200, or 300 respectively. Well, that is now out. That is not in the current 2012 guidelines, and we no longer do it that way. And the reason is this paper that came out down here in 2011. And in that, they showed that really the risk of allopurinol hypersensitivity syndrome is incredibly low. Even in people who have chronic kidney disease, we practically never see it. And they went a little further and discovered that it's in certain ethnic groups. So there are certain ethnic groups that you need to be careful with. The Han Chinese, Thai, and Koreans who have stage 3 chronic kidney disease or worse. In those folks, we now have a genetic test that we can do, the HLA-B5801. And if you're going to start allopurinol in that group of people, you need to check this, and if it's positive, then don't use allopurinol. And yes, that's on the ABIM. You've got to know this exception, okay? So in general, everybody's going to get allopurinol, but if you're one of these folks, you're going to check this test. If it's positive, you're not going to give allopurinol because of the risk of allopurinol hypersensitivity syndrome. You're going to push the dose of allopurinol above 300 milligrams if necessary to achieve a serum uric acid of less than 6, even in chronic kidney disease in everybody else. Febuxostat is also a xanthine oxidase inhibitor. It works like allopurinol. There are a few subtle differences. We don't obviously see the allopurinol hypersensitivity syndrome with febuxostat. So early data indicated that it might be safer in people with kidney disease, but that's really controversial because in those studies, they did not use equivalent doses of allopurinol and febuxostat. The other thing with febuxostat is if your ALT goes up or your total bilirubin goes up 2 times the upper limit of normal, you need to stop this medicine and not restart it. It seems to be the equivalent of the allopurinol hypersensitivity syndrome. In this case, it's a liver hypersensitivity. It's not hepatotoxicity like you see in a lot of other drugs. In many other drugs, you might be able to stop the drug, let the liver heal itself, and restart at a lower dose. In this case, you can't because it's a hypersensitivity reaction to the liver. Don't restart febuxostat if you see elevation of your liver tests. So again, both of these medicines are xanthine oxidase inhibitors, and therefore they both interact with medicines like azathioprine and 6-mercaptopurine. You've got to think about that in the patient who's had an organ transplant. Okay, someone's had a kidney transplant and now they're walking into your emergency room with a gout attack. Maybe their 3rd one, and you're thinking about using one of these medicines, but their transplant physician has them on azathioprine. You've got to be really careful there because it will cause problems with their bone marrow. Both of these drugs alter theophylline metabolism. They both cause GI side effects. And in febuxostat, again, we think about this risk with the liver, whereas with allopurinol, we think about the allopurinol hypersensitivity syndrome. Probenecid is different. It works differently. And we would never use Probenecid in people with a history of kidney stones because it works by promoting uric acid excretion. So we wouldn't want to do that to someone who's predisposed to have kidney stones. It also doesn't work well if your GFR is less than 50. Unfortunately, that excludes a lot of people with gout because this tends to be the population of people who has a low GFR. You can get blood dyscrasias with it, and it's also recommended for combination use with xanthine oxidase inhibitors for refractory cases. Pegloticase is a fabulous drug. It works really, really well. So the reason we as human beings get gout is we don't make an enzyme called uricase. There are other creatures on this earth that also don't make uricase, like Dalmatians and alligators also get gout. So scientists took the enzyme uricase and pegylated it, and it's now available as a drug that we can give. Obviously, if you just gave uricase without pegylating it, you would get terrible infusion reactions and hypersensitivity and anaphylaxis because it's a foreign protein. It's incredibly expensive. It's indicated for refractory gout or those with a high disease burden, and there's always a risk of infusion reaction even with the pegylated molecule because it is a foreign protein. The risk of infusion reaction increases if your serum uric acid level is going up. So if you've been giving somebody infusions of febuxostat, pegloticase, and you check a pre-infusion uric acid and it's above 6, you know that the last infusion didn't work very well. In other words, the patient's immune system ate up the drug so that it couldn't do its job. And now if you give them this drug on today's visit, when their uric acid is high, you risk causing anaphylaxis. So we always check a pre-infusion uric acid level and decide, based on that uric acid level, whether they'll get their infusion. This is one of those drugs that causes problems if you have G6PD deficiency as well. The newest kid on the block is a drug called Lesinurad, and it targets the urate-1 transporter in the kidney, and it's indicated for use in combination with xanthine oxidase inhibitors, and we would not use this medicine if your GFR is less than 45. This was just FDA approved in December. I've still had a hard time getting it, but it's available now. So other treatments for gout include regular exercise. We want people to achieve their target BMI. Don't get dehydrated. And there are really 4 big points with diet that I make for everybody who has gout. Avoid alcohol overuse. and that's defined as more than 2 servings per day in a man or more than 1 serving per day in a woman. For some reason with gout, beer is much worse than wine and distilled beverages. You should avoid shellfish and sardines. We want to avoid organ meat, and which is things like chicken liver, foie gras, and sweetbreads. And this other point that I've already made, we want to avoid high fructose corn syrup, which is hard to do because it's hidden in everything. If it comes in a box or a package or a can, you need to be a label reader about high fructose corn syrup. So gout has other complications. The hazards ratio for cardiovascular mortality is 1.38. So people who have untreated gout die sooner than people who have gout that gets treated. Right, here's some of the evidence. So treating it is important. As that urate burden builds, you get what's called urate nephropathy, which is literally microscopic tophi in the glomerulus, so your kidneys don't work well. It's important to treat it for that reason. And chronic gout leads to a destructive polyarthritis that can look very similar to rheumatoid arthritis. So if you get arthritis that looks like this, obviously this person, again, has non-functional hands, complete destruction of these joints, and this is never going to come back. Awful. So we don't want to let it get like this. Unfortunately, I still see about 1 of these a month. They're more common than we want. Gout and organ transplant creates a big problem. There's often rapid fluid shifts. There's often the use of calcineurin inhibitors like cyclosporin and tacrolimus. So if you've got gout in someone with an organ transplant, that's definitely a reason to refer to a rheumatologist. Most gout is treated by primary care physicians, but gout that's complicated in an organ transplant needs to be seen by a rheumatologist. So for example, in someone who's had a kidney transplant, we might use a half of a colchicine one time and not repeat it for 3 days. That's the kind of dose we might choose. We use joint injections a lot because joint injections are really safe in these folks. We consider increasing their steroids, and we might consider adding interleukin-1 inhibitors. It turns out that inhibitors of interleukin-1 are fabulous treatments for gout. They're just really expensive. And if we've got someone who's got hands like the ones I just showed you, it might be appropriate to go for an IL-1 inhibitor. Keep in mind that xanthine oxidase inhibitors interfere with azathioprine, and if renal function is adequate, you'd consider probenecid or pegloticase. A 74-year-old woman is evaluated for a 2-year history of progressive pain in the fingers and knees, along with morning stiffness lasting 20 minutes. There's no other pertinent personal or family history. Her only medication is acetaminophen, and she's afebrile, her blood pressure is normal, pulse is 66, respiratory rate is 12, and her BMI is 19. Her musculoskeletal examination reveals tenderness, erythema, soft tissue swelling, and bony hypertrophy of the 2nd and 3rd metacarpal phalangeal joints bilateral, and bone hypertrophy and swelling of both knees is present. Laboratory data includes erythrocyte sedimentation rate, ferritin, iron, TIBC. They're all normal. The transferrin saturation is not elevated. Rheumatoid factor and anti-CCP antibodies are negative. And X-rays show joint space narrowing, osteophytes, subchondral sclerosis, and this linear calcification of the cartilage. Pick out that statement. The triangular fibrocartilage of the wrist also demonstrates this calcification. Radiographs of the knees show diffuse joint space narrowing, osteophytes, and again, cartilaginous calcification. There are no marginal erosions or periarticular osteopenia. So which of the following is the most likely diagnosis? Calcium pyrophosphate deposition disease, hemochromatosis, osteoarthritis, psoriatic arthritis, or rheumatoid arthritis? I'll give you just a minute to think about that. All right, let's see what we've got here. So, excellent. Calcium pyrophosphate deposition disease. That slide's way too busy. This linear calcification of the cartilage was the clue in that question. And that tells you that there's chondrocalcinosis. That's a radiographic term. We'll get to that. But I've presented a case here that's typical of calcium pyrophosphate deposition disease. It's not rheumatoid arthritis. There's no periarticular erosions. Even though you've got synovitis, your rheumatoid factor and anti-CCP antibodies were both negative. And it's not psoriatic arthritis because, again, there are no erosions. And you've got this linear calcification of the cartilage, which is kind of the clue in that question. So, CPPD can be acute arthritis, chronic inflammatory arthritis that looks for all the world like rheumatoid arthritis, chronic osteoarthritis, or it can be asymptomatic, just radiographic findings of chondrocalcinosis. So all of these things are included under the heading of CPPD. Chondrocalcinosis, again, is a radiographic finding. It's not a disease per se, it's a radiographic term. And it can be due to CPPD or basic calcium phosphate disease. So pseudogout is no longer the preferred terminology for this disease. We're getting away from that. Pseudogout means not gout, and it sort of begs the question, if it's not gout, what is it? So we call it what it is. It's CPPD. And that's the preferred name for it now. In 2011, EULAR, which is the European League Against Rheumatism, recommended that calcium pyrophosphate crystals be referred to as CPP crystals, hence CPPD is calcium pyrophosphate deposition, and we say CPPD disease. It's a mouthful. Chondrocalcinosis, again, is the radiographic term. It most commonly presents as acute monoarthritis, and the most common joint affected is the knee. The clinical picture is indistinguishable from gout, from septic arthritis, and sometimes even from rheumatoid arthritis. Attacks often last a little bit longer than in gout, more like weeks to months. It tends to have a more chronic, more smoldering course than gout does. There are a number of diseases associated with CPPD. Hyperparathyroidism, hypothyroidism, hemochromatosis, hypophosphatasia. Be sure you look that one up. Hypomagnesemia, and if you look at what's most predictive of CPPD, it actually turns out to be this one right here. If your magnesium level is low, sometimes just correcting the magnesium level makes this disease vanish. It's associated with Gittleman's variant of Barter's syndrome. And familial hypocalciuric hypercalcemia. So my workup for these diseases is going to include an iron, a transferrin, a calcium level, ALK-Phos, a PTH, a TSH, phosphorus, magnesium, and a metabolic panel to look for these other causes of CPPD arthritis. CPPD is often found in the context of osteoarthritis. They seem to be linked. Both are common in advanced age, and in at least one study here, when they look at the knees that were removed from people who had a knee replacement for osteoarthritis, in at least 20% of just all comers, they found CPPD crystals. Medications can cause CPPD. All of these are more controversial than they are with gout. It's less well studied, it's less well established. But intra-articular hyaluronan preparations, diuretics, again including hydrochlorothiazide and furosemide especially, granulocyte macrophage colony stimulating factor, and pamidronate have all been reported to be possible causes of CPPD. You're going to suspect this clinically in someone who has chronic osteoarthritis in atypical locations like the wrist. You're going to suspect it in someone who has chondrocalcinosis radiographically, and you're going to diagnose it by aspirating the joint. So here is chondrocalcinosis, this linear calcification. in this case in a shoulder. Here we've got the same thing in a knee, this line of calcification that you're seeing. And this, for the most part, looks like a normal x-ray of the hand until you get right here. And right there in the triangular fibrocartilage is this pocket of calcification. That's chondrocalcinosis. And these tend to be short, stubby needles, short, stubby crystals that are not needle-shaped, that are weakly, positively birefringent. They just don't light up as much as gout crystals. And again, here's the compensator plane. And if this was yellow in parallel, you'd think gout, but in this case it's yellow perpendicular. You know it's CPPD. So again, yellow in parallel is gout, blue in parallel is CPPD. It can be a polyarticular disease that resembles osteoarthritis, and it can also have an RA-like phenotype that looks for all the world like rheumatoid arthritis, with swelling of the MCP joints, swelling of PIP joints, and it can present with spinal disease. So this is a picture from the recent review in the New England Journal. I was so happy when I picked up the New England Journal last month, and this was the review that was in there with CPPD. You should read that if you're interested. A lot of that I'm going over here, but this is a great example. If you just looked at this hand, you'd say, well, there's swelling here in MCP joints. We've got a PIP that's swollen, another PIP that's swollen. This, for all the world, looks like rheumatoid arthritis, but if you aspirate one of these joints, you see this. And this is very typical of CPPD arthritis, where you get these short, stubby crystals that don't glow as brightly as they do with gout. Treatment is with NSAIDs, colchicine, and corticosteroids, and some people require long-term treatment. In some cases, we use immunosuppressive medications like methotrexate to control this, especially if it's in an RA-like phenotype. For chronic CPPD, colchicine, NSAIDs, hydroxychloroquine, methotrexate, and the IL-1 inhibitors have all been reported to be beneficial. With this disease, we don't have randomized controlled studies to guide us so much on the treatment. The last resort are the IL-1 inhibitors, but these drugs, again, just like in gout, work fabulously well. They're really expensive, but they just make the disease vanish. So last case, a 72-year-old woman is evaluated in the emergency department for severe right shoulder pain and swelling. 3 weeks ago, she injured her shoulder when falling from a stepladder and went to the emergency department. Radiographs of the shoulder revealed soft tissue swelling. She partially improved, but the pain and swelling came back after several days and are gradually getting worse. She's been taking acetaminophen for the pain, but it doesn't seem to help. Her vital signs are normal. Her right shoulder is swollen, red, tender, particularly over the anterior surface, and the range of motion elicits pain, and it's limited. She can't abduct her shoulder. An X-ray shows significant soft tissue swelling and a possible large fluid collection. There is a hazy overlay of calcification around the entire joint, and the joint itself is eroded. Aspiration is performed, and you get this blood-tinged fluid with a high leukocyte count in the synovial fluid. But if you look at this under your microscope, you don't see anything. There are no crystals at all. Gram staining cultures are negative. So which of the following is the most likely diagnosis? Basic calcium phosphate arthropathy, hemochromatosis, calcium pyrophosphate deposition disease, or rheumatoid arthritis? I'll give you just a few more seconds to think about that. Okay, let's move on here and see what we've got. All right, so everybody's getting these right. I like that. So basic calcium phosphate arthropathy is what we're after here. And what I've given you is a description of Milwaukee shoulder, is what this used to be called. So basic calcium phosphate disease is another crystal-induced arthritis. It's more common over the age of 50. It's very common in joints that have already been affected by osteoarthritis. And it can cause acute arthritis or chronic, highly destructive changes, for example, what we're seeing here. And basic calcium phosphate crystals can also affect periarticular structures like the bursa, ligaments, tendons, and outside the joint and in the muscle even. You diagnose this by clinical suspicion and the radiographic appearance. The crystals are tiny and non-birefringent, so you really need an electron microscope to see these. There is a special stain that you can use. I have a hard time getting this stain done even on pathologic specimens by our pathologists, but there is a stain that can be used to see these crystals. And you treat symptomatically with nonsteroidal anti-inflammatory drugs, colchicine, or corticosteroids. And so here it is, this sort of mass beside the shoulder, and this is definitely not bone. It's not trabeculated. It's outside the joint. This is actually from basic calcium phosphate disease. So in summary, some take-home points. Do not treat asymptomatic hyperuricemia. You're always going to confirm a diagnosis of gout with joint aspiration or an X-ray if there's any suspicion. And you're going to use allopurinol first line to treat chronic gout more than 2 episodes per year at 100 milligrams per day and titrating the dose to get the uric acid less than 6. You're going to expect gout attacks when using urate lowering therapy. So you're going to counsel your patient and you're going to use some kind of prophylaxis for about 4 to 6 months when you start urate lowering therapy. And you're going to be aware of other types of crystal-induced arthritis like CPPD and basic calcium phosphate disease. And that's it. Any questions? Yes?
Is Urate only used in tumor lysis because it's really effective as opposed to Pegloticase, more expensive maybe?
It's actually equally expensive to Pegloticase. It's only FDA approved in tumor lysis syndrome, and that's really the reason, is that insurance companies won't pay for it. It actually works really well in gout. It's one of those things where the company went for a specific indication. It's an expensive drug, and unfortunately now insurance companies will only pay for it for that indication. Yes?
Are mechanical means part of the treatment of the profile?
Mechanical means. So far, mechanical means have not been shown to reduce the tophaceous burden. There is some data on that. I'm not an expert. I can't quote you all that data, but it's not recommended in the 2012 guidelines for treating tophaceous deposits. Did you have another one?
Yeah, and when you stop the
Febuxostat,
yeah,
yes.
the expensive one because of the liver enzymes. Can you switch allopurinol?
Yes, you can. You can, yes. Absolutely.
Is there any role for urinary alkalinization for hyperuricemia?
For urine alkalinization for hyperuricemia, yes, in some cases that does work, and sometimes we will use that, especially in people who are on dialysis and have dialysis-related gout. I wouldn't say it's a standard treatment. It's low down on the list. And if someone's having an acute gout attack, it's not terribly effective. But if you're in a clinical scenario, again, especially in somebody who's on dialysis, it does help. Yes? So for a patient who has confirmed uric acid kidney stones, the answer is yes. That is an indication to start urate lowering therapy, really lifelong. And the same reason holds. You can get urate nephropathy, and that's, again, microscopic tophi in the glomerulus, and you can destroy a kidney that way. And so we treat it.
Just a follow-up question. What is the level? I know we normally we say less than 6, but then with kidney stone, the same.
In the rheumatologic literature, that still reads less than 6. That might be different in the nephrology literature, and that's a little bit of an arbitrary cutoff, 6. The physiologic concentration at which uric acid falls out of solution is 6.7 at, sea level and, normal temperature and pressure. So they made this 6, but lower is better. So if it's 4 or 5, you're going to have less of a problem. Great. Any other questions? Thank you for having me. Yes.
Do you follow